to help them to go to the healthcare facilities. But she's not doing that because she thinks she has the ability of managing to help this mother to give birth. That's why we are saying delays in seeking care. So you're going to find she has not helped the mother to go to the healthcare facility, and the baby is either going to die or the mother is going to lose life. Thank you.
Thank you so much, our worship judges and the two contending chambers. I would like to cross-examine the first negator from the negative side. Can you remind me of your house? Our worship judges, you can take note of that. Do you mind when you tell me about your standpoint? Our worship judges, you can take note of that. Our worship judges, I would like the first negator to tell me about their parameter.
The parameter is Uganda, and that's the parameter we are using.
Can you define for me what a system means?
A system is a combined, structured and organized group of people that join together to do something.
Our worship judges, they came here lying the whole house, and yet they didn't defend about the key terms. Thank you. You said that the TBAs never exist in Uganda. Can you present the evidence on the table of the judges that they don't
exist? I didn't say that. You quoted that wrong. You are not attentive.
You said it clearly. Thank you.
I didn't say that, sorry.
Can you define for me what traditional birth attendants mean?
Traditional birth attendants are people that assist on mothers to give birth, but they are not well qualified, and they get the skills by delivering the mothers themselves or by assistance of other traditional birth attendants.
Our worship judges, I would like her to define for me what health means. Our worship judges, you can take note of that.
I can explain that. You're not giving me time to explain that. Thank you. I arrest my case.
The issue is not just a moral imperative, but a pressing concern that demands our attention. Ladies and gentlemen, honorable judges, fellow debaters, today we gather here to discuss the critical issue that is, this House believes that This House believes that traditional birth attendants should be integrated into the formal health care system. And my side, we are the affirmatives, and we still affirm the resolution of the House due to the views that we have as follows. First of all, we have increased accessibility, as my first speaker said, and the next that is preservation of culture. Preservation of culture, whereby in Uganda we do believe that the Constitution gives us the right to belong in each and every culture that we do believe in, whereby these traditional birth attendants will help us to maintain the traditional culture and local customs related to childbirth, whereby in Uganda some of the societies believe that when a mother gives birth to twins, and there are ceremonies that are done towards those twins, and most of them, I can't term it in English, but most of them call it amahasa. So, and the Baganda call it kumara abalungu. That is it. Next on our point, we have trust. These traditional birth attendants have gained trust, have earned trust of the community members, which can lead to more improvement in the positive health care outcome of Uganda, whereby this is where the government has tried to put all over each and every sub-county to have a health center 3, whereby you find they are trained midwives, they are employed in those facilities, whereby you find a mother, she cannot go to that health center 3, she decides to go to that traditional birth attendant, whereby she says that I'll produce all my 9 children into this person. Why this 10th? Why me going to the hospital? Why means this traditional birth attendant has gained access and trust of the community that she can do that thing better. So that's why we are saying that they should be put into the whole system care of Uganda, whereby we can train them, get the basics of that, how they can do it, so that they can do the best care that they can provide to the community. Next, that is flexibility. Flexibility whereby these traditional birth attendants, they can come to the patient's home, deliver the mother, if at all we train them and have those and have the skills and techniques whereby they can identify complications. If there is a complication and she cannot manage, she can either refer to the hospital or the health center where they can manage further, whereby they can do cesarean section and the rest. Whereby if the mother cannot go to the traditional birth attendant's place, the traditional birth attendant can go to the mother's side and the birth practice is done. Next, we have postnatal care. We believe that in the hospital we have a lot of load to do, whereby you find a midwife is alone on duty, whereby she has around 16 mothers. Some of them have delivered today, others delivered previously yesterday, whereby she cannot attend to all of those mothers alone, whereby this traditional birth attendant can be trained in order. If a mother is discharged from the hospital, she can go home and still be cared by that, after that, be cared after by that traditional birth attendant. So that's why I say we should always do what? We should incorporate these traditional birth attendants into the health care system. So those are the points that I can give. Whereby the first speaker on the negative side said that the government is trying to, to abolish, whereby I stand saying a no to that point. You say the government is abolishing the traditional birth attendants, and I'm saying no. Whereby the government is trying to empower the traditional birth attendants under the PHC ministry, whereby they are bringing them into collaboration with the Ministry of Health and other health sectors, so that they can provide the best care in. So that's what I can say in the country, whereby you are in that same side, whereby you have PHC and we have collaboration in it. Thank you, our judges.
Thank you. So I heard you telling us that the government is trying to bring the traditional birth attendants into the system. Do you have evidence for that?
I said it's not blaming them, but it's supporting.
I asked, do you have evidence for what you said?
Yes.
Present the evidence.
Because it is supporting the TBS with the PHC.
Thank you. I would like to know the percentage of women in 2025 that are still going to traditional birth attendants.
Currently, we still have the current study that was in 2018 done by the World Health Organization.
And I would like to know, how are you going to integrate those mothers? So some ways that you're going to integrate those mothers.
Integrating this, it's not integrating the mothers, but integrating the TBS.
Okay. Thank you. So how are you going to do it?
So we had a work plan of 3 years, whereby we shall first do research and also registration of these birth attendants in the whole country. And that would be the first year. Second year, we should do the training and the implementation, whereby we shall train. And after training, we shall implement the training. And the third year, we shall evaluate and deploy them into the dependent.
So how sure are you that in that 1 year that you're going to use to train them, they are going to learn everything?
So it's not that we want them to learn each and everything, but we want them to get the basics of preventing the risks practices.
I disagree with that, because with the evidence that I have, as I gave you an example of Maria, who is a 53-year-old traditional birth attendant, she is integrated. But she's still doing the things that are not acceptable in the society. She's still using the rings to dilate the vagina of the mother if the baby is too big. She is integrated. She said it by herself that she is integrated by the government, but she is still doing it. So that means even if you integrate them, they are still going to do the practices that they have to do because they still believe in those practices.
Our first inquiry from you, do delay the vagina or do delay the cervix?
Amasanyalaze gawulira. Maximum respect goes to our honored adjudicators, our esteemed opponents, and my attentive audience. So I stand here to speak against the resolution which is saying that traditional birth attendants should be integrated in the healthcare system, and of which it's going to bring more harm than good. Progress is not achieved by clinging to the past, but it will be achieved by boldly confronting their limitations. Yes, we believe traditional birth attendants have played a historical role, but let history not be a license to jeopardize our standards as the healthcare system. So, our former speaker, the second speaker from the affirmatives, you've talked about the political issue. You've said that this is a political issue that you're trying to implement. But I would like to assure you that this is not a mere policy, but it's a sanctity of life, which should be handled with a lot of care, and not just like that because we are following our good intentions. You also talked about culture, and I would also like to assure you that childbirth is not a cultural ritual that should be. It's not a cultural ritual that should not be changed, that we should carry on the habits and the practices that traditional birth attendants have always been using and bring them in our system, and hence it's just going to dilute our system and practices that we have in the healthcare system, and hence in our country we want just to keep the good standards and the uniformity in our healthcare system. So what you said that these people are going to be early detectors, but I would also like to assure you and let you know that these people that you're calling early detectors, they will be institutionalizing delay. How will they be doing this? You think that they will be the early detectors, and yet we already have some people there in the community. The community-based healthcare system is containing the village health team, and whereby we have people that can earlier detect those cases that need to be reported to the healthcare system, and we can reach there to those people and increase the accessibility through those village health teams that are already existing, rather than bringing these people into our system who are going just to dilute our standards. So my first view as to why I'm saying that we should not include them: the traditional birth attendants lack formal medical training. By now, they lack formal medical training. And even if you claim that you're going to train these people, however much you're going to train them, they will not learn the exact procedures and the steps that for us we are using in the healthcare system. They are just rather going to dilute our standards and bring in the practices of the cultures, and of which we are saying childbirth is not a cultural ritual. They delay in seeking professional help. You're saying that they are early detectors, but these people will be delaying The mothers that would have been reported to us by the village welfare team who are not traditional birth attendants that will bring to us the information quickly, it will be intervened in by the other traditional birth attendants who already think that they know everything. When they get to know that there is something, there is a case that they can also handle, so they will waste time dealing with it, and yet they can't even manage it. Instead of these people doing such wasting time, let's just use the people who are already there in the community-based healthcare system who will be helping us to get to know all those cases that need to be reported to us. Standardization and regulation challenges. We shall not include them because they are just going to dilute our standards. Potential undermining of skilled birth attendants. They are just going to undermine our skilled birth attendants, like the midwives and the nurses will no longer be having any importance now. The moment the traditional birth attendants start doing such, then that means we should not need even to invest our money in the hospitals where we have the midwives and the nurses. Conflicting practices, they will bring their cultural practices whereby they have to use dangerous herbs and of which may be harmful to our mothers. Resource allocation. Instead of allocating those resources like money and the support that we may be giving those people under training, let's give it to the midwives and the nurses in the institutions in order to develop our system. So I conclude by saying that let's not gamble with child or with maternal health, because it's very crucial for us to consider it as something important. Okay, our worship judges, I would like the current speaker to tell me what is culture. So the culture, those are the practices that the people in the community consider to be right, that have been doing from generations up to now.
Take note, judges, the current speaker doesn't know the definition of culture, and now you have talked about VHTs, and VHTs, these are people that the former healthcare facility has trained to go and help those people in villages, and we are talking about lack of formal medical training. We already have them, so there is no need for integrating. If we have VHTs and they can give those dilemmas house per house, so we can have traditional birth attendants attending to mothers house per house. The traditional birth attendants are different because for them they think that they already know everything. So let me ask you, so we are talking about anything and they were just trained. We are talking about lack of formal training, and you told us that traditional birth attendants can't learn. I want you to tell me what is forcing you to say that traditional birth attendants can't learn. Excuse me, wait, I'm still asking you. We have students here who come from homes where their mothers are traditional birth attendants. You want to tell me when they reach the hospitals, they will be doing what their mothers do, or they will be doing what they are trained to do. That means they can also come like they were. The only reason that's why I'm saying they cannot learn, these are just mere relics of a bygone era. They think that the practices that they know of the culture can never just easily. So you mean, I have asked you, we have students here whereby their mothers are traditional birth attendants and they know everything. So they came here in 1.1 and went in a midwifery class. So now they know what to do according to the medical formal system. So now you want to tell me they will be doing what their mothers do in villages? That means the way you learned when you came here in 1.1, that's how traditional birth attendants are for training. Thank you, our dear judges. I'm still asking, time is there. I'm asking, I want you to tell me the prevalence at which mothers are dying giving birth in traditional health attendants, and you tell me why are you not allowing us to train the death? I've not talked about death. Our worship judges, the two containing chambers, and the house at large, good morning. My name is Binjola Evening.
Resolved, this House believes that traditional birth attendants should be integrated into the healthcare system. My standpoint is completely affirming, saying that I'm completely affirming. Our worship judges, allow me to first go on what the current speakers on the negative side have been saying. The first speaker said in her views, she said that TBAs do not exist. But at the same time, she gave us an example of a lady called Maria who got issues in delivery. Meaning that these people are well informed that TBAs exist, but only that they need skills to be integrated into the healthcare system. So our worship judges, I request the negative side to carry their seats and join us so that you can support this resolution. Our worship judges, first and foremost, the negators are here arguing about the resolution and yet they do not have a house. So if you don't have a house, why are you arguing? Why are you wasting your energy? Just carry your seats, join us because you don't have a house and you are here complaining about the resolution. Can you complain without having a lien for where you can lead? Our worship judges, I request them to carry their seats and join us because they do not have a house. So why are they lying us here? Our worship judges, they came here saying that they came here with that as a standpoint, and so I request them, with a humble request, I request them to carry their seats and join us because they don't have a standpoint. Meaning that they are supporting the affirmative side. Since we don't have a standpoint, you are supporting the affirmative side. Thank you. Our worship judges, they said that TBAs are most causative agents of most mortality rate of mothers and babies. Do you believe that currently the mothers who are dying today, they are dying from health facilities? You mean they are dying from TBAs? Thank you. Our worship judges, the first speaker asked our second speaker to that's how will he integrate TBAs into the health system, and our second speaker clearly answered her that we have our plan, whereby in our first year we shall make thorough research and registration, second year training and implementation, third year evaluation and deployment, meaning that they were not concentrating on the resolution, they were in their own businesses. Thank you. So their first speaker, instead of asking questions, she was trying to answer them back. So we were here for cross-examination. So you are the one asking, you are not supposed to be answering questions. That means you are in support of our resolution. You should carry your seats and join us. Our worship judges, at this very moment, allow me to go straight forward into our views. Our first view was increased accessibility. Our worship judges, we all know that most of the healthcare facilities that are situated in towns, they are in the heart of cities. In villages are left aside. They do not have any health care center. They do not have any health facility. Instead, mothers are there suffering. So because of that, mothers have resorted to TBAs. Meaning that TBAs are very important in the society and they are highly needed. So that's why we are here to give them more skills. Thank you. They talked, my speakers on the affirmative side said that they are reduced costs, whereby reduced costs here we mean in normal delivery when you go to Virika hospital it is 150 and cesarean section is 500,000. Our mothers here, they are peasants, they are in the villages suffering, they do not have good paying jobs, so that's why they resort to TBAs, whereby TBAs you do not need to give them much money, so they are the readily available people who are there to help these mothers deliver safely, rather than the mother going in the hospital. They do not work on you, they need money of which you don't have it, you don't have any source of income, so that's why they're resorting to the TBA so that they can help them, and they are doing that successfully. Our worship judges, they said about trust. Trust, this is whereby you find a mother has delivered 12 children, that's a dozen of children. Most of them have been delivered by the TBAs. So this mother will gain trust more in this TBA rather than going to the health facility, whereby she will find there people whom she's not very flexible with, whom she's not fair with, whom she's not used to. So she would rather resort to the TBA rather than going to the hospital, whereby she will find this arguing midwife who will instead be slapping her, who will instead be abusing her. So why would she go there? She would rather go to the TBA whom she's already with you and she has trust in her. So our worship judges, I completely stand here affirming that TBA should be highly integrated into the healthcare system of Uganda because of the following reason: increased accessibility, reduced cost, preservation of culture trust, flexibility, holistic approach on care, community participation, prenatal care. And as I conclude, I request the negators to carry their seats humbly and join us so that we can support our resolution. Thank you.
So, previous speaker, thank you. I would like to know, dear judges, the competing sides, and the House at large, good morning. Good afternoon to you. So standing before you is Karis Dokas, a student midwife in Virika. I would like to inform the third speaker from the affirmers that in the debating format of Kalpopa, the negators are not supposed to state the parameters. I think you don't know that, but it is in the format of the Kalpopa method. Thank you. And I would like to know the funding body. You did not tell us your funding body. I would like to know your funding body. They may not. So, and the second speaker was like, they're going to dilute the culture, but I would like to tell you, childbirth is not a cultural practice. It is actually a biological activity that has to happen despite the presence of culture or its absence. And I would like to know, are you trying to teach these traditional birth attendants midwifery? Because you're going to integrate them in the healthcare system is going to make them feel that they can do everything. They can carry out, they can handle emergencies like eclampsia, uterine rupture, fetal distress, amniotic fluid going to return secondary, transverse line oblique, which they actually cannot do. So you're going to make them think that they can actually handle these emergencies, yet they can actually not. So, my dear judges, the resolution of today states that this House believes that traditional birth attendants should be integrated in the healthcare system, and I stand here completely saying no to this resolution. And also, they told us that they are going to train these traditional birth attendants. But I would like to tell you, my dear judges, that traditional birth attendants are very old women in the villages. And if you have heard of a disease that as a person ages, their memory and understanding deteriorates. So, these traditional birth attendants are not going to understand all these emergencies. And they are going to think that they can handle the emergencies, and they're going to try, and guess what they're going to try to do? They're going to try to deliver these mothers despite of the fact them discovering that they cannot actually handle the emergencies. They're going to try to deliver the mothers, and we are going to lose our mothers and babies. And as a midwife, this hurts me very much to one day hear that a mother out there and a baby have died because a traditional birth attendant tried to deliver, yet they do not have the knowledge, and they're telling us they're going to train them. We're going to, traditional birth attendants, as I've told you, my fellows, are very old people. They're not going to understand everything. They're not going to be they're not going to be able to understand all these emergencies. And how will they be able to tell you guys, to inform you that they have emergencies? They are going to try to manage these emergencies there in the villages, and guess what is going to happen? Mothers are going to die, babies are going to die because of you integrating the traditional birth attendants in the healthcare system. I disagree with these people, my dear judges. And they are telling us that traditional birth attendants can be succeeded by their children. So,
these people, the children that are going to succeed to these traditional birth attendants are also not going to have the knowledge about childbirth. So they're going to just lead to the death of our babies and mothers while they try to deliver them. My dear judges, these people are not informed about the issue why Uganda tried to ban traditional birth attendants. Well, let me tell you something. In 2010, there was a chaos about a woman called Salome who went to visit a traditional birth attendant, and guess what happened? She had an emergency that she was not supposed to deliver the baby in the traditional birth attendant's place, but the traditional birth attendant tried to carry out a cesarean section, and guess what? They did not suture. They left the mother to heal, and the baby had to die because the traditional birth attendant forgot to cut the cord in time. She forgot, and guess what happened to the baby? The baby had to die. So my dear judges, I do not agree with the farmers to integrate the healthcare system with the traditional birth attendants, because children are going to die, my dear judges. Babies are going to die. Babies and mothers are going to die because of the integration. And who is going to be responsible? Who is going to be responsible? Guess what these people are going to do? After them integrating the traditional birth care attendants, they are going to neglect them. They are going to neglect them, and in case anything happens and the traditional birth attendant is responsible for the death of the baby, they are going to move aside and they will tell the police, take the traditional birth attendant. It's the traditional birth attendant responsible for the death of the mother and the baby. So I meant to my point, agreeing that the traditional birth attendants should not be integrated in the formal healthcare system because of these points: lack of formal medical training, delay in seeking professional help, standardizing the legislation and challenges, potential undermining of skilled birth, conflicting practices, resource allocation. Thank you.
I told you the winning team is coming. Are you seeing it? Anytime from now. Next on our agenda, we have remarks from the judges as the next debaters prepare. So, at this juncture, allow me give the mic to our dear judges.
Okay, attention ladies and gentlemen. Attention. Now what is going to happen is that after every debate session, the judges engage in deliberation. Deliberation means that each and every judge explains who they think has won, because it's not a one-person decision. So each and every judge will explain who has won here. We make deliberations on why, then we reach a consensus. So I will be bringing feedback to you in a few minutes, so you'll have to wait anxiously. Meanwhile, you people shake hands as a gesture of being friendly and professionalism in debate. So for the time being, let's do a deliberation. We shall announce who has emerged victorious in this round.
You either win or learn. So as our judges do the deliberation, is the entertainment minister ready? A chance. So as the entertainment minister comes in, is there any midwife who has a word to say, or anyone from the audience? Thank you so much, Madam Speaker. I am a midwife by profession,
And for me, I was on the side of those people who are saying that TBS should not be integrated because the government is actually trying to phase out enrolled midwives. And now you are talking about TBS, you are not serious. Thank you so much. Thank you so much, the speaker. Me, as a midwife, I am saying we should integrate traditional birth attendants. Reason being, for a reason being, these people are living with our mothers in the communities, and they reach them before you midwives reach them. So I am saying we involve them and help them refer mothers to our responsible facilities. Thank you very much.
Okay. Good afternoon, everyone. Hello. Order. Good afternoon, everyone. I'm Richard Chalgonza, and I'm a comprehensive nurse. I'm now doing a diploma in nursing. Okay? As the motion was reading that the TBS should be integrated, for me as a comprehensive nurse, I'm saying no. Okay? Reasons. These TBS, they don't even know to read their names. You get? These are mothers who are old in age, and you grow in age, there is dementia. Okay? Why? Okay? The TBS, they don't even know the anatomy and physiology of the female reproductive system. Okay? Instead, the government should reduce the costs of school fees for midwives, so that we can have more midwives and have safe work delivery. Thank you.
Yes, with all due respect, maximum silence, give me audience. With all due respect, my standpoint, I'm on the negating side. So my point of view is that due to the fact that we have nursing institutions, the affirmatives were saying that the traditional birth attendants. My question is, why do we have the nursing institutions? Why wouldn't the traditional birth attendants train us from the village, and then we be trained health professions? Due to the fact that we have the nursing institutions, we need the professional training so that we can be integrated into the healthcare system. Hello everyone. Bodriva Nyangoma is my name. I want to tell you, now when you're there, we are doing PHC, we are doing community health. Midwives and nurses, we do PHC and we do community health. Why do we do it? Because we want to mobilize these people. That's why in community health, we have the community-owned resource persons. And we are integrating. We are not doing what? That's why the motion is integration. Thank you so much. And I think we are done. If you have an issue, you will come in the other session, because our judges are done and we should be preparing for the next session. Thank you very much.
Okay, attention ladies and gentlemen. Attention.
They have said that you should put your issues in the comment section.
Attention. Attention, attention, attention. So let's all listen because we are going to deliver the verdict. Whatever you've been saying has been judged. And the discussions can always continue informally. As you walk to the dining, as you are in your social hour, later on you can discuss. Okay, so listen. I'm going to give what was required in this debate, and I'm going to give a justification of why the one who won this debate wins it, and why the other person doesn't win this debate. And my justification is going to be based on the basic principles of debate, and not the social principles that we use outside debate. Yes. So listen very carefully. So we had a resolution in our midst, and the resolution went like, this House believes that traditional birth attendants should be integrated into the formal healthcare system. So, for every resolution that is presented to you in a debate, behind it is what we call the spirit of the resolution. The spirit of the resolution means, what was the resolution trying to solve? Why was that resolution set up in the first place? For example, looking at this resolution, it presupposes that there was a problem of insufficient healthcare services. Because the fact that this resolution talks about integrating more manpower into the mainstream healthcare system, it means there was a problem of insufficiency. That's one. Two, when we look at the insufficiency, so if we look at the problem of insufficiency, what does that mean? It means we are tasked with the responsibility to close that gap of insufficiency. So, what would be needed from anyone who wants to support this resolution? In debate, there's what we call a preemptive argument. A preemptive argument is whereby you look at a problem, make a few admissions, and then suggest solutions to the problems that could be existing in that particular case. For example, let me look at the affirmative team. What would we have required from an affirmative team in this particular case? As an affirmative team, you would acknowledge that the problem in this resolution is we have insufficient manpower in the mainstream healthcare services. Guaranteed. But what is the challenge? The challenge is that we have a group of people, traditional birth attendants, who are not skilled enough to handle these cases that exist in society. So, amidst that acceptance, you don't have to always deny everything. You can accept that as per the status quo, there is an insufficient and there is a skills gap. But we need to solve the insufficiency. So, now it goes to how you solve the skills gap, because if you acknowledge that there is a need to have these people to close the gap, so how do you skill them to put them in position to be able to close that specific gap that you're talking about? So, this is where the affirmative team argued about the trainings that they want to give to these birth attendants. So, from the affirmative side, we picked ideas like trying to reduce the cost of health services, increasing accessibility, and all that in the affirmative case. So that was the bedrock of the affirmative case. They showed us that there is an insufficiency, and they want to close that insufficiency by skilling these people so that they can provide additional or complementary health services to supplement on what the professionals are already giving. So, however, what we wanted to hear more from the affirmative team was, to what extent will these traditional birth attendants be involved? Because there is an acceptance that these people cannot be involved to the extent of providing the work that is being done by professionals. So, we needed to hear that. So, let's look at what we expected from the negative team and what they brought up in this debate. So, as a negative team, we expect you to adapt to what is coming into the resolution. So, what would we remotely expect from the negative team? What we would expect the negative team is not necessarily to tell us the disadvantages of having traditional birth. That the affirmatives are trying to bring in, for example, to train these traditional birth attendants, those efforts will not be sufficient enough to solve the problems that could arise from using traditional birth attendants to provide this childbirth care. I'm not a professional, so I'm going to use very basic words. So, So we are going to look at the negatives. So the negatives are supposed to show us if the affirmatives are saying that we need to train. How effective is the training? Is the training going to make these people professional enough to provide the services that we want? Because in actual sense, at the end of the day, the negative team will have a duty to rebut. You don't always have to die with the content that you have. You don't have to tell us the disadvantages of traditional birth attendance, but you're supposed to show us how effective or how not effective is the strategies that the affirmatives are trying to bring into the debate. So, basically, this debate was judged on burdens. Who executed his burden better? So if you are a negative team, did you refute? Did you try to poke holes in the strategy of the affirmative team? And if you are an affirmative team, did you justify that your strategy is the most efficient in this debate? Those are the final questions in the debate, and the central question is to be specific. So, after all that, in considerations, all the three judges agreed that the affirmatives win this debate.
So, winning team number one got. Without wasting time, allow me introduce. Yeah, we are having an interlude. Entertainment Minister. Entertainment Minister. Please come and give us some immediate Christo here. I give you electricity. The debate minute, the what? The entertainment minister has refused to come.
Meanwhile, the next group of debaters should be preparing. The diplomats, as the entertainment minister comes in, the diplomats should be preparing.
Ministers refused to come. For us, the ones who have won, we can dance. Oh, thank you very much, our entertainment minister. She's really doing the job, eh? Next time I'm coming on podium with her. So next on agenda, we are commencing the second session. I hope the debaters are ready. Are you ready?
We are ready.
I think we are ready to go.
Madam Chairperson.
Yes, attention. Madam Chairperson, Yaliwa.
The guy we wanted to hire is already in the position side.
let her show you from here.
Dear Speaker, be patient. Our dear judges will notify you when to start.
The chairperson, our dear judges, my fellow debaters, the audience, ladies and gentlemen, good afternoon. My name is John Tumsime, Honorable John Tumsime, and I'm here to affirm this motion. This House believes that donor-aided health financing impeds sustainable health service delivery in developing countries. I would like to take a few minutes to expound a few words coherently so that my opponents can see how this motion is very important. The key terms here, we have a donor. A donor is a giver of something like money or time to help others or support a cause. Therefore, a donor-aided health financing means the support given by foreign countries and organizations to help pay for health care in poorer countries like Uganda. And this support can be in form of money, it can be in form of medicines or doctors to deliver services. And impede means to delay or hinder or to negatively affect progress. Sustainable health service delivery means having a strong, reliable health care that can be maintained for a long period of time without external support. Developing countries, there are countries that are still developing, growing economically, improving things like healthcare, education, and infrastructure. And these countries, we believe, they are the countries with low to middle income. And for example, Uganda, Kenya, Tanzania, Zimbabwe, and of course, I have a list of developing countries that was updated March 2022. This is the reference. This motion debates whether financial support from donors hinder the ability of developing countries to build long-term self-sufficient healthcare systems. And of course, we are here, as I told you before, we are here to support this motion with the following views. One, the donor-aided support creates dependency. Two, it creates short-term focus for donor projects. Distortion of health priorities, lack of accountability and ownership, and unpredictability and withdrawal risk. Fragmentation of health systems. I'm going to expound a few points so that my colleagues can continue. For example, the first point we said, creating dependency. Most of our developing countries have been supported, for example, in programs like HIV, and these have created dependency, and these countries are slumbering, they are dreaming, they are sleeping, so they cannot wake up to do their own and sustain the host institutions. For example, you see what happened in January 28th. January 28th, Donald Trump, on his coming to office, he somehow stopped these grants to Uganda. You see what happened. But because they could not sustain Donald Trump again lifted this ban. So we are still depending on these countries, and we are still sleeping as Uganda. This is very bad for us. The second point on is distortion of health priorities. Like Uganda is a developing countries, these donors, they come and give us a few areas they want support. And they give us a period. For example, they will say they will support HIV for a contract of 5 years, and after that, we shall remain and not able to sustain what is the better health facilities, health services. So therefore, we shall not be able to deliver sustainable health service in Uganda. And we are using Uganda because this is the parameter we have used. We, as our team, we started because we see we don't want to depend on donors for long. We started a poverty alleviation charitable organization called Nyawiyo. Nyawiyo, it is an abbreviation of National Youth and Women Initiative Organization. So we want to sensitize the country on how we can have self-reliance on our own. And you can visit the website, Nyawiyo Organization, or www.nyawiyo Organization for references. Thank you.
Okay, thank you very much, Honorable, for the points given. And from what you have presented, I would like to inquire, do you believe that the incident that you have mentioned that happened on 28th Jan, do you believe that it affects the sustainability of the services in a way that most of the population were scared that they will no longer get ARVs? Some of us were out of jobs and we were not providing health services?
If Trump had stopped, and in fact that is the reason why he lifted the ban, because he saw we cannot sustain.
No, my question is not yet answered. I'm saying, do you believe that when the aid was stopped, when the donation was stopped, we were affected as people, as health workers were affected, and as the community which were benefiting from getting these services, like people who are getting drugs, people who were getting mosquito nets? Do you believe that there was a threat?
You were a health worker, you saw what happened, and up to now there are some organizations that have stopped. Those that were supported, those who are getting donations, they have already stopped, and they have, and we as health workers, we were so much affected. And of course you can see what happened, because we could not sustain. That's why Trump again lifted the ban.
Confirm with me, do you believe yes or no? Say yes or no.
By explanation, you understand, you can be able to tell. Thank you, the audience, ladies and gentlemen, for listening. I pray that you can join and support and affirm this motion. Thank you for listening. Madam Speaker, esteemed panel of judges, timekeeper, our for opponents, and the honorable audience, I greet you all.
Motion: this House believes that donor-aided health financing impedes sustainable health service delivery in developing countries. And we are having parameters of Uganda. That means we are majorizing Uganda as a country. Let me start with definition of key terms. A donor or donors. These are individuals or organizations that provide financial support to causes, charities, or initiatives often to drive positive change or address social issues. Health is a state of physical, mental, or social well-being of an individual, but not merely absence of a disease or infirmity. Impeding definition. Impeding means to slow down or obstruct the progress or movement of something or someone. Sustainability refers to the ability to maintain or support a process or activity over time without depleting resources or causing harm to the environment, society, or economy. I rise with fervor and full intellectual conviction to vehemently oppose the motion that donor-aided health financing impedes sustainable health service delivery in developing countries. Our team line is simple yet profound. Donor funding is not a developmental crash. It is the catalyst, the compass, and the capital for sustainable transformation within Uganda's health sector and other developing countries. Here I present my points. Number one, donor aid is a systemic multiplier. Donor-aided health financing can fill critical funding gaps, enabling countries to provide essential health services. That is according to World Health Organization in 2010. Donor aid has acted as a shackle but a systemic multiplier, transforming mere existence into functional efficiency. Uganda in 2023 alone received over US $900 million in a donor contribution to the health sector. That is according to World Bank 2024. This support enabled over 1.3 million Ugandans living with HIV to access life-saving antiretroviral therapy through PEPFAR. As Dr. Seth Buckley of Gavi once noted, sustainability is not achieved in isolation but through catalytic partnership. Let us not forget that over 70% of our immunization programs, courtesy of Gavi, would collapse without this critical aid. This is not dependency, this is strategic empowerment. Point number two, capacity building and technological transfer. Donor-aided programs can build local capacity, strengthening health systems and improving health outcomes. That is according to Martinez Alvarez et al. 2017. Sustainability is built in human capital and institutional competence, both fruits of donor engagement. CDC and USAID have trained over 80% of Ugandans' epidemiological surveillance workforce. Our entire district reporting infrastructure, including DHIS2 and M-Track, are donor funded. Capacity is not innate, it is transferred, built and fortified over time. That is Dr. Agnes Vinagwaho of Rwanda. I end by saying that donor aid has not replaced our systems, it has professionalized them. Thank you so much.
Thank you, Honorable. Good afternoon. I would like to kindly ask our current speaker, can you please clarify how you define sustainable health financing in the context of donor aid?
Thank you so much. In the context of donor aid, so I had defined sustainability. So when you go to the context of donor aid, it means a donor, when is bringing some aid, they always sign contracts with you. That means in the same contract, they will clarify on the sustainability of the service
Judges, I
provided.
think that since you have not responded, don't you think that lack of an investment can lead to lack of accountability in our country, since you're talking about Uganda, since you're clearly stating the funds that are taking place and how they are funding the country?
Repeat.
Sorry. I'm saying, you're talking, you've given us how the funding is taking place. Can you please see that there is lack of accountability in everything you've spoken about and all those funding, donor-aided companies that are funding Uganda?
Thank you so much. You're saying there is lack of accountability, and I think this lack of accountability is brought by us who are receiving the funds.
I think you've heard. That's
Yes.
what I wanted.
Thank you so much. Actually, when the funds come, it is us ourselves who misuse the funds, starting from DHT downwards. So when people don't receive services, we should not blame those donors. We should blame ourselves.
Thank you, Honorable. In your words, you talked of something like environment.
We must not be penny-wise and pound foolish by relying on donor funding that undermines our long-term health goals. My name is Honorable Karunga Christina. I'm here to affirm this motion that states, this House believes that donor-aided health financing impedes sustainable health service delivery in developing countries. As the precurrent speaker, he clearly stated systemic multiplier twice without him explaining how this systemic multiplying explains and takes place in the country when it is related to sustainable service delivery in Uganda. That means he clearly didn't understand the meaning of service delivery that is sustainable. Okay, so my urgency is to, since we targeted Uganda as our parameter, short-term focus on donor projects. This we read through the Journal of Global Health 2018. Short-term projects based in nature of donor funding can lead to lack of long-term sustainability in health programs. Take an instance that these donor funds that are given to the country, they have short-term notice to an extent that it's not guaranteed that it will take part forever. No, this gives the country this gives the developing country like Uganda a challenge on how to sustain these issues in the country. I can give an example of these programs like cleft palate programs, fistula programs. These do take place, you'll find once a year. Take an instance of our population in Uganda having these conditions raised each and every day. And you find out that the only chance they get to have this program is once a year when they will hear of that program taking place.
leaving it out for Uganda not getting a chance to form its own way of how they can tackle and handle these various problems and diseases. Lack of accountability and ownership. Donor aid can bypass all local governments, reducing accountability and transparency. In these developing countries, especially like Uganda, there is misuse of global fund money in Uganda, and that is a challenge we're trying to get rid of. In case Uganda takes a stand and fights on its own and sees on how to pattern and work with these funding programs, then it can be in position to account and be able to pass a trust and efficiency of donor funds that have been reported. Fragmentation of health systems. Donor aid can lead to parallel systems that undermine the integration of health services. These developing countries that have donor-funded programs, they operate independently of the Ministry of Health. This hence creates insufficiencies and duplication. The proliferation of donor-funded vertical programs for HIV in Uganda have sometimes diverted sources to use them to do some other things instead of sensitizing and helping these primary healthcare systems. Then donor priorities over local needs. These funding programs, they ensure to prioritize and give instructions and conditions on their programs that they are funding. For instance, as Uganda, you find our most population is being affected by COVID-19 and malaria. It only tackles the HIV part and hence not working on the choice and priority of the country that it needs. Unpredictability and withdrawal risk. I can, for instance, give an example of the I can give an example of the ban that has been uplifted. There was a question to my first speaker whereby he said, he was asked that, does he agree that there was commotion? That is what we're trying to eradicate. If we are not dependent on these countries and we form solutions on how to overcome these challenges, then that commotion would not have taken place. Thank you.
Thank you so much, Madam. You said in your points that the donors are giving us donations on short-term notes or short-term help. And I'm here to give you a point of correction. Mosquitoes have been given out for long, and it has been a donor-funded program.
Okay.
First wait, I finish, and then PEPFAR, then Bahila Uganda, has been there for years. Is it as short notes or short
okay.
help?
Are you done?
Yes.
I would like to ask if you made research. Those contracts are only how can I call it? They are just
Thank you so much.
They are just reinforced after. It's just a due time. And mosquito nets, if you try to ask people who have received mosquito nets, they will tell you it's a guarantee that it's not an every time privilege. It's a once in a while privilege, targeting a few and a little duration of time.
Madam, I work in a government health facility, and I'm a midwife. We always have those mosquito nets, and I'm talking out of experience, not out of
experience won't work. I got the evidence that it's just a...
Madam Speaker, our esteemed judges, timekeeper, our worthy opponents, and our honorable audience, I greet you all. This House believes that donor-aided health financing impairs sustainable health service delivery in Uganda, in developing countries, and for me, I'm here to I am firmly against this motion, and I'm giving the following rationale. Number one, we have global solidarity and health equity. Uganda's ability to respond to global health threats like COVID-19 is inseparable from global solidarity. Uganda received over 45 million vaccine doses through the COVAX facility. ICU beds in Arua, Mbale, Fort Portal were built through Global Fund and WHO interventions. So I am strongly agree that we cannot be separated from these fundings because two people are more than one. My point number two, we have emergency response and epidemic containment. When Ebola struck Uganda, who mobilized ambulances, isolation centers, they gave us PPEs, and those things were so much help to our country. So I agree that maybe if we didn't receive the funds, maybe we could not have passed through COVID-19, which was a threat to us. And without donor-aided rapid response, we are at a risk of national collapse. We are at risk of not just national collapse, but a regional catastrophe. Then another point is legal and government reforms. Aid is not given blindly. It is structured with conditions that strengthen accountability and law. The National Health Insurance Bill, birthed from donor-led feasibility studies, it is an evidence of reform via ethical conditionalities. My another point is addressing neglected health areas. Government funding for mental health remains below 1%. Donors stepped in and they had to give in a hand. Thanks to UNICEF and European Union, they have done a greater job in so many areas in our health care. Then I'm giving an example, like Beira, Uganda has been here I think for more than a decade, and has transformed so many people's lives in different regions, mostly in this Renzol region, and people have benefited. So I conclude by saying that we need these funds to sustain our health service delivery in these developing countries. Thank you so much. I'm waiting for questions.
Thank you, the current speaker, and thank you for supporting our motion, because most of the points you've given are affirming. Thank you. And you remember this donor aided house financing is like a house built on sand, vulnerable to collapse at any time. You remember what happened during COVID-19 that they're talking about, and they cut off the support. And you remember what the president of Uganda did? He called out businessmen to come and support to overcome COVID. So thank you for supporting us. Thank you so much.
I'm not supporting you, Mr. Speaker. My point is, do we need or do we don't need? I say we need. If you are talking about the issue of those donors withdraw, yes, they can withdraw, but before they have withdrawn, so many people have benefited, so many lives have been saved, mothers have not died.
That is why I'm saying you're supporting us, because when you say they withdraw, is that sustainability? First thing for us, what is sustainability?
Sustainability, this is a way of maintaining and providing continuous care.
So they are withdrawing, are they maintaining?
They may withdraw at a certain point, but they have helped.
Thank you so much. That is why we are farming, because we know this is not sustainable. And the point like I told you before, we are sleeping. When they withdraw, we are going to be left in slumber.
Before you talk about sustainability, you have to see the aid that is on ground. People have been helped and people have been saved. Then you can come later to sustainability. Thank you.
Hope the judges can see that you
Okay. Thank you, the current speaker. Honorable Chairperson, our dear judges, the principal in absence, Patron Honorable, and my opponent side, and the audience at large. Good afternoon. I'm Richard Jalgonza, and I'm here standing with my two legs affirming the motion. Has the motion been read to you? I think by now everyone knows it. My fellow opposers, do you know that free things are always bad? And what I know that you all have homes. You are coming from home, your wives, your husbands. Do you depend from outside? Do you have support from outside? If you can stand on your own legs and support your family, then the country, how can the country fail to stand on its own? So, I'm giving you the solution, what the country can do so that it can stand on its own. Domestic resource mobilization. The country can mobilize resources on its own from the people. You heard in COVID what Museveni did. He mobilized for support. And people came in, they brought cars, they brought money, food, etc. And we moved on. Partnership. Fostering partnerships between government, donor, and other stakeholders to ensure alignment and coordination. The government should instead partner with the donors, okay? And they get some services rather than waiting for the donors to support us. Capacity building. Are you aware that the country itself has the capacity to build support for the LSA system? Are you aware of that? Are you aware? You will tell me after. The country-led LSA financing encourages the country-led LSA financing strategies and plans. The country should come in and get some strategies and see how they can manage emergencies rather than depending on the donors. I want to inform you that, are you aware that some services which we are talking about, they were phased out? We have evidence. Okay? We are speaking from evidence. Here is the evidence. There are some projects which were stopped. Okay? They were stopped by the donors, even including the mosquito nets. Can you tell me where they are giving the mosquito nets now for free? In conclusion, by promoting sustainability, LSA financing strategies, the country can reduce their dependency on external aid and ensure long-term access to quality and LSA care services. Thank you.
You long press. All right. Madam Speaker, the esteemed judges, the timekeeper, and the honorable audience, I greet you all. I am here to oppose the motion that says this House believes that the donor-aided health financing impedes sustainable health service delivery in the developing countries. And I'm here to oppose this motion due to the following points. And before I get to that, I would like to inform the opponents. Some opponents mentioned that
donors do not, that donors hinders accountability. That's not true. Most monies that have come, most funds that have come through donors have been accounted for, so that's not true. Then another point that say that communities are being affected because donors are prioritizing on HIV. That's not true, because as we stand here, this house that we see here that we are standing on was constructed by the donors, from the monies from donors. You can see from the other thing, from the building, it is very indicated, and that wasn't meant on HIV. Mosquitoes have been supplied through the Ministry of Health. Different services have come out, not necessarily on HIV. Then you have also talked about the withdrawal of funds, that it can affect sustainability. That's what we are talking about, that if donors stop, sustainability can be affected. So we need the donors in the developing countries. Some other points to oppose this motion are the infrastructures that have been made. Even as we talk, the lower common and the upper common was from the funds, the aiding funds. It was constructed by the donors, by the European Union, and it is supporting health sector by training us. If we were still studying under the trees, maybe this school wouldn't have been sustained, and it would affect the sustainability of provision of health services. Another point is that donors have helped in supporting the digital health information system, which has supported the proper reporting. You know, as we use the system to report this information, it easily helps the Ministry of Health to adjust on the services that we are giving. For example, as we are working now in our health centers, as we go to Buhinga, as we go in our health facilities, as we put in the information, it goes direct to the Ministry of Health. And they use that information to do direct interventions and adjust on the health provision services. And it helps in sustaining the health service provision. The donors have also helped in sustaining of health services provision by continuous supply of pharmaceuticals and promoting the supply chains. As you mentioned, the incidents that happened in January on 28th, 2025, it really happened, and it was a threat to the continuity or to the sustainability of the services. And it happens because the donors were withdrawing. So I still stand that we do need the donors. Another point why we need the donors is overemphasis on the vertical programs. Okay. Specific, when we are in our facilities serving, there are different services that have been handled by donors. They don't specify on specific services. They provide different services. They have handled different sectors of health. So they have really promoted to the sustainability of our health services. 75% of Uganda's essential drug stock comes from donor pipelines. I would like you people to be informed that 75% of Uganda's essential drug stock come from donors. Donors' aid has not impeded sustainability, it has engineered it. It has built our hospitals, trained our nurses, digitalized the system, and vaccinated our children. Okay, thank you very much for listening.
Thank you very much, our dear speakers. I think we've come to the end of our second session. And right now, I think our judges are going to be in prep. as they prepare to tell us who has emerged as the winner of the second session and who has learned from the second session. We are going to hear from different people. If you know you're there and you have something to supplement.
Thank you so much, the speaker. Good afternoon, ladies and gentlemen. One thing that we need to learn in this debate is that if you do not win, you're taught. And the one who loses the debate learns. And as we are debating here, we state the reasons for us either being negators or affirmers to this motion. And as you debate, you should be clear with your speaker roles. Where speaker number 1 is going to open for us this debate and give us the introduction, and speaker number 2 gives us the body, and speaker number 3, you support your other speakers and give us a summary of what has been said. And then you manage your time very well. As per this motion, some of us did not have where we stand. You come here, you start your discussion, you've not told us whether you're negating to the motion, you're not affirming to the motion, and you're telling us, I think we all know. If you say we all know, how sure are we that you know? So when you come and stand here, be clear and play your speaker roles well. This is one of the areas where you're scoring speaker points. The motion is about, this House believes that donor-aided health financing impedes sustainable health service delivery in developing countries. And we've clearly given definitions for the key terms. When we talk of a statement like it impedes, it is slowing down service delivery. And when you're discussing here and someone tries to make your point invalid, you also do not stand and you're supporting them in that regard. When someone tells you there is lack of accountability, and then you stand and tell me it is because I'm misusing the funds, you're shooting your own foot. When they give a statement like that, make sure you're defending your point to make it valid for you to score speaker points. And then when you say these people are withdrawing the support, take an example like what Donald Trump did. If he says, I'm withdrawing this support, is it going to make this service delivery sustainable? Or when he withdraws this service, which means we do not have sustainability. You remember our definition of impedes? It is slowing it down. So service delivery at one point is going to be slowed down. You get? So when you say they are withdrawing the aid, and then you support them, which means you're telling them that it actually impedes or it slows down service delivery. So you are affirming that this aid, that all the financing aid, is actually slowing this down. I personally work with a donor-aided facility. At times you request for something and they're like, you know what, you can wait. Which means the item you wanted to use is not going to be in position, and then the service is going to be slowed down. So every time you're defending your point, make sure you have a valid reason and to keep your point valid. The moment they make it invalid, you're losing points. Thank you so much.
And I think our judges are ready to give us the outcomes of the second session. Meanwhile, after the judges give us the remarks, the other two teams that are going to be coming for the third session will be preparing as we are for lunch. So after the judges give us the final remarks, we are going to go into a lunch break.
So maybe to add on what she's saying, immediately we finish announcing the winners of this round, we are going to have, of course we shall already have lined up who is in the final. We shall pick the one who won earlier on versus the one who has just won this round, as we are going to announce. So what we're going to do in this case, we are going to have one representative from the team that won the first round and the team that will win this round. They will come here, pick sides, we give them the resolution, and then as they have lunch, they will be in position to prepare for the final round. So let's first have the verdict, because that will make sense when we have the verdict.
Okay, thank you so much, Paul. And it is very helpful for the debaters to have a handshake, so to give them the verdict. It is very helpful.
Maybe hard after the verdict.
Otherwise, after receiving the verdict, you may time to